Hello again, friends. This will be an update to a lecture that I gave way back in 2013 on peptic ulcer disease and gastritis. As you know, I've had some lectures for some reason that it's come to my attention that the audio hasn't been working, so I am updating those lectures and obviously hoping to get to you a lecture that actually does have sound. So that is why I am updating this, but I do have some more information to add to this. There have been changes in the last 5 years, but for the most part, the diagnosis and treatment remains pretty similar to what it was before. So this will come up on the USMLE. Peptic ulcer disease and gastritis are the number 2 causes of epigastric pain. So you do want to understand these approaches and how we go about treating this. It will come up on the test. If you haven't had the opportunity yet, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can get there by clicking the link below in the description of the video or on the I button on the upper right-hand corner of your screen, and it should link you up. If you consider chipping in $1 a month, a little bit goes a very long way to help keep these videos free. And if you subscribe, you'll have access to some of my premium content in which I go over case reviews, how to formulate differential diagnosis, treatment plans, things that will come in handy for you in your clinical practice, and especially as you get ready to study for USMLE Step 3, which, as you know, you will need to have a good systematic way of going about things because there is a portion of it that is not multiple choice. So thank you very much in advance for your consideration, and now let's talk about peptic ulcer disease and gastritis. So here we are in our digestive tract. We're going to be focusing on the stomach and the first part of the small intestine, otherwise known as the duodenum. So you can have ulcers either in your stomach or in your duodenum. They're a little bit different. However, for the most part, you can't really tell them apart clinically. Gastritis is different. As you know, ulcers are ulcers, but gastritis is simply inflammation. So they are different, but again, very difficult to distinguish clinically. Your approach is going to be the same. The difference is how one will respond and the other really won't so much. So we will go into the intricacies of how these are different. Obviously, from a pathologic perspective, they are quite different, but from a clinical perspective, they can be a little tricky to differentiate. Luckily for us, the approach is very similar. So when it comes to answering Step 2 and Step 3 questions where you're not given pathologic specimens, it should be pretty straightforward to go at these. So, as you know, the causes of epigastric pain, the number 1 cause is idiopathic. However, when you do know the cause, the number 1 cause, if you've ever worked in an ER, you would know that the number 1 cause is certainly GERD. And GERD often presents as chest pain. I would say 95% of the patients who come into the ER with quote-unquote chest pain actually have reflux disease. And it makes sense because when you have reflux, it's actually going up the esophagus, the pain, and the esophagus goes right through your chest. And of course, when you're 50, 60, 70 years old and you start having chest pain, that's duly an alarm sign for something more problematic like a heart attack or something. So these patients come in and they're worried about having a heart attack. Of course, we go and wire them up to an EKG, get cardiac enzymes. We find that it's normal. Most of the time, those patients are GERD. So whether or not that presents as epigastric pain, we don't really know, but we can safely say that the number 1 cause of epigastric pain is GERD just because it's so common. Beyond that, peptic ulcer disease and gastritis are the number 2 causes. Pancreatitis, a little bit further down, certainly causes pain, but the pain scale is going to be way higher when it's pancreatitis, especially in its acute form. Look for a history of alcoholism in patients with pancreatitis. Typically, the pain is so bad it goes right through to the back. So these patients are in really severe pain. Like I said, look for a history of alcoholism. Not always present, but it is in many cases. Others include esophagitis, cholecystitis, cholelithiasis, cholangitis, diverticulitis. Those are not epigastric pain, but they can be referred to maybe refer isn't the best word, but they can manifest in the epigastric area, but they'll typically, if you ask these patients, they will have pain elsewhere. So with esophagitis, that pain will often go from the back of their throat all the way down to the epigastric area. Cholecystitis, cholelithiasis, cholangitis, as you can imagine, is going to involve some right upper quadrant pain. And diverticulitis will typically be lower, but they can all involve the epigastric area. So when you ask the patient to point to where their pain is, they may point to the epigastric area. So you always have to consider these in your differential. Of course, cancer is a possibility. Look for alarm signs like weight loss and anemia, fatigue, and things like that. So that can be gastric, esophageal, pancreatic. These can all cause epigastric pain. And then referred or misappropriated pain, kind of going along the same lines as these others that I put up here. Pelvic pain can get referred up to the epigastric area. So if you're dealing with a woman of childbearing age, you always have to consider the possibility of a pregnancy, of an ectopic pregnancy. And so a pregnancy test is always good to get in any woman of childbearing age who has abdominal pain. It's a very cheap test, very easy to get, and you can rule out one of the more problematic causes of abdominal pain. So always take that into mind when you're taking step 3. That should just be a reflex for you. So you need to remember to order a pregnancy test when you're dealing with a woman of childbearing age who has abdominal pain, even though it may look like an ulcer or may look like pancreatitis or may look like GERD. If you're dealing with a woman of childbearing age and she has abdominal pain, please, please, please get a pregnancy test. So peptic ulcer disease, as mentioned, along with gastritis, the number 2 most commonly diagnosed cause of epigastric pain when the cause is known. It is a focal ulceration of the stomach or duodenal tissue. The profile of this pain is that it tends to occur after eating. A lot of times patients will refer to this as a gnawing pain that comes and goes in waves. Now, you may read in review books that with gastric ulcers, it tends to occur during eating or maybe very briefly after eating. Whereas with duodenal ulcers, it tends to be relieved by eating and then comes on a few hours after eating, postprandial. That's not always reliable. So you really can't differentiate between gastric and duodenal ulcers by symptoms alone. And it really doesn't matter because the causes are the same. So we're always thinking NSAIDs or H. pylori. So the way we are going to go about treating this is the same. So it's not super important that you know the difference as far as clinical presentation between gastric and duodenal ulcers. You know, step 1, I think when I took step 1, I did get a question on gastric or duodenal ulcers, although I took step 1 like going on like 8 years ago. So, you know, this is a long, long, long time ago. So I really, for all intents and purposes, when you're practicing clinically, it doesn't matter, and it's really not reliable to go on the nature of the symptoms as far as eating. Does it go away or does it not? So that's just a rule of thumb, but really you can't rely on that. The only way that you can know definitively if it's gastric versus duodenal is to do a scope, and that's not something we're going to do on all patients. But as you're going to see, it'll come a little bit more clear that it really doesn't matter so much because the way we are going to approach this is going to be the same, regardless of whether we think it's gastric or we think it's duodenal. Remember that ulcers can occur as part of a larger disease process. So certainly in Crohn's, remember that can affect anywhere from the mouth. You can get aphthous ulcers in the mouth all the way down to the rectum. Crohn's, you get ulcerations really anywhere. Whereas with Zollinger-Ellison syndrome, again, you can also get ulcers, but this, remember, Zollinger-Ellison syndrome is due to a gastrin-secreting tumor. So with Crohn's, look for people with lower GI symptoms like diarrhea and lower abdominal pain. They may have some alarm symptoms like weight loss. Zollinger-Ellison syndrome, it can be really tricky. It's very rare, thankfully, but look for a history of MEN1, multiple endocrine neoplasia type 1. It tends to present as part of that complex. So do keep in mind that ulcers can be a symptom of a larger disease process. The causes of peptic ulcer disease, far and away the most common causes are NSAID use, ongoing long-term NSAID use. So think a patient that is older, maybe has osteoarthritis, and is taking an NSAID long-term. And then Helicobacter pylori. Think of younger people who really don't have any other risk factors for peptic ulcer disease. Typically, H. pylori is behind those. So these make up the majority of cases. And like I said, there are other syndromes that can manifest with ulcers. Head trauma, remember that's your Cushing's ulcer. Burns, remember that's your curling ulcer. Mechanical ventilation, and then as mentioned, Crohn's disease and Zollinger-Ellison syndrome. All patients should be tested for H. pylori, and typically that's going to be the first thing that we do as far as getting at what's the diagnosis. Even if the patient is on NSAIDs, you're not going to just drop it and say it must be NSAIDs. You do want to still test these patients for H. pylori if you have reasonable suspicion that they have an ulcer. All right. So remember to keep in mind your gastrointestinal alarm symptoms. So you should always remember these. Anytime you have a patient with GI symptoms, if they also have one of these alarm symptoms, then your approach is going to be a little bit more emergent, and you're probably going to move on to endoscopy because you really want to find out what the cause is. Really, when we're talking about alarm symptoms, what we're worried about is cancer. And gastric cancer, esophageal cancer can mimic ulcer disease as far as the pain goes. You know, you can get pain from those things. And so whenever you have a patient who has alarm symptoms, you want to you want to take this into consideration. So if you have a patient with weight loss, anemia, heme positive stools, or hematemesis. So I say heme positive stools, really what I'm talking about is melena. Heme positive would be like a lab result. So if they have dark stools, if they have hematemesis, we're thinking of a bleed. So anything consistent with a GI bleed. Early satiety, adynophagia or dysphagia, or they're older than 45, then you really want to think of maybe scoping these patients. Not always, but just bear in mind these symptoms and use your clinical judgment. So remember that one of the very first things that we are going to do is test for H. pylori. This will almost always be part of your workup when you suspect an ulcer. So there are several commonly used ways to test. Serology is going to be the most sensitive. Now, if a patient has an infection with H. pylori, they will always test positive on serology because you have an infection, you mount an immune response, so you'll have a positive serology. And it will always be positive even after you treat these patients. So this is the most sensitive test to diagnose H. pylori. A gastric biopsy is obviously going to be more specific because you can actually see the bacterium. There are a few different tests that you can do with the biopsy specimen, but the most time-tested way is to actually look at it under a microscope. Obviously, this is going to require endoscopy, so it's not necessarily going to be the first thing that you go to. Certainly, if you have reason to want to scope these patients, if they have alarm signs, then yeah, sure, get a gastric biopsy while you're down there. Stool antigen checks for present infection. So this is really good to use if the patient doesn't respond to therapy. It's also very commonly used to see if the patient is actually responding to therapy. A stool antigen will go away if the patient responds to therapy. So unlike the serology, a stool antigen, if you've actually resolved the H. pylori infection, that will then test negative. So serology will always be positive if the patient's ever had an infection with H. pylori. Stool antigen will be positive if they have an active infection, but then within a few days of eradicating the H. pylori, it will then be negative. So it's a good test to check for response to therapy. And then there's the urea breath test. The problem with the urea breath test is that the patient has to discontinue their proton pump inhibitor for a couple weeks prior to doing the test. Sometimes these patients have been on proton pump inhibitors, either over the counter or prescribed. And so, you know, the patient is going to have these symptoms, they're going to have pain. It's difficult to tell them to go off your PPI for some time prior to getting this test. So for that reason, stool antigen tends to be preferred. It's just easier. The best first step in management of a patient with suspected peptic ulcer disease is therefore H. pylori serology. It is the most sensitive test. As long as they don't have any alarm symptoms that makes you think, well, maybe they have cancer or maybe they have an active bleed, then go ahead and get H. pylori serology as your initial step. The most accurate test for H. pylori infection is gastric biopsy. That is your gold standard. So going back to peptic ulcer disease, what are the symptoms? So it can be postprandial epigastric pain. It can be pain with eating. It can wake the patient up in the middle of the night. Maybe this is quote unquote heartburn. They might describe it as heartburn that doesn't respond to antacids, or maybe they have alarm symptoms. Some of these or all of these can present and be the presentation of peptic ulcer disease. The history, you may have frequent NSAID use, very common in older people who have arthritis. They take NSAIDs and then they develop an ulcer. But they don't necessarily, you can have a younger person who's never touched an NSAID in their life and then they develop an ulcer. So you don't have to have that. Roughly equal distribution between men and women. Diagnosis. So, as we said, patients without alarm symptoms, the first thing that you should do is get an H. pylori serology. You're going to do a number of other things for these patients just to make sure that there's nothing else going on. So, you're going to get a CBC checking for anemia. You're going to get a CMP just because, it's possible that it could be right upper quadrant pain when in fact it's presenting as epigastric pain. So you want to check those liver enzymes just to make sure that there's nothing else going on there. You want to get a B12 for reasons we're going to go into, and MMA along the same lines. Remember, that's your methylmalonic acid. And then an occult stool blood. Sometimes they may have a bleeding ulcer and it's just very lightly bleeding, and so they won't have melena, they won't have obviously hematemesis, so you want to make sure that they're not actually bleeding. So anytime you've got a patient who you think has an ulcer, just check to make sure they're not bleeding. An occult stool blood test is very, very easy. You just go in with your gloved finger, get a little bit of stool out of their rectum, smear it on that on your little paper, put the drop on there, and then you see if it turns, I think it's blue, then it's positive. And then, that's considered an alarm symptom then at that point. So consider that. Patients with alarm symptoms should receive endoscopy. So certainly if they have an active bleed, if they're really old, if they're a smoker and alcoholic where you might suspect cancer, if they have weight loss or pain with swallowing, then you should probably go ahead and do an endoscopy. The treatment. So once you've diagnosed peptic ulcer disease, then you want to put these patients, so assuming they test positive for H. pylori, you want to put these patients on triple therapy. So H. pylori positive patients, you want to put them on triple therapy. And triple therapy is going to be a proton pump inhibitor like omeprazole, along with clarithromycin and amoxicillin. So those three drugs should be given to patients with H. pylori positive peptic ulcer disease. If they're H. pylori negative and you still suspect peptic ulcer disease, then you're only going to give them a proton pump inhibitor. Obviously, we don't treat them with antibiotics if they don't have H. pylori. You should consider discontinuing NSAIDs if possible. If it's not possible, you should consider replacing with a COX-2 inhibitor, but remember there are contraindications for that. Obviously, if they have a cardiac history, you might want to be a little bit more careful about that, maybe refer them off to a cardiologist to make the definitive judgment as to whether a COX-2 inhibitor is right for them. But for the USMLE, you should take into consideration that a COX-2 inhibitor is typically used for patients who need NSAIDs who have GI symptoms that really make NSAIDs prohibitive. If it is H. pylori, remember to follow up 2 to 4 weeks later to confirm eradication, and we typically do that via stool antigen test. Now, what if the patient doesn't respond to treatment? So if it is an H. pylori ulcer, after a couple weeks, if there's no improvement in symptoms, or if the symptoms recur, or if they continue to test positive for H. pylori, then you should consider getting an endoscopy and then also changing the antibiotic regimen. So you're going to go in with an endoscopy, get a biopsy, and then see if it's actually H. pylori, and then if it is, you'll want to change their antibiotic regimen. So you can do an alternative regimen. This includes metronidazole with tetracycline, and then also your proton pump inhibitor, which doesn't need to change. You can also add bismuth. That would constitute a quadruple therapy because you're using 4 drugs, but that's not necessary. If it's a non-H. pylori ulcer, then you're going to follow them up after 6 to 8 weeks. If there's no improvement in symptoms, then you're going to go ahead and do an endoscopy. And at this point, we're really looking for gastritis and the differential for gastritis. So do alcohol and tobacco cause ulcers? You always hear about alcohol and tobacco associated with ulcers. Does alcohol actually cause an ulcer? Does tobacco cause an ulcer? Think of that. The answer is no. But what alcohol and tobacco do is that they delay healing. So if you already have an ulcer, sometimes an ulcer can come on and it can heal on its own. If you are a frequent drinker or if you smoke, if you get an ulcer, it's less likely to heal on its own, and then it can become symptomatic as it worsens. So it does increase your risk of developing a symptomatic ulcer. Some people have ulcers and they're not symptomatic. So if you're doing anything that delays healing, then certainly you're more likely to manifest symptoms of an ulcer. Okay, so complications of peptic ulcer disease, the big one is perforation. So with perforation, they're going to have much more significant pain. So they'll report a history of, ulcer-like symptoms, pain with eating, sort of gnawing pain that they've been dealing with for a long time, but now suddenly the pain is way worse. And what will happen is that they start developing peritoneal-like symptoms. Very sensitive to touch, any kind of movement, rebound tenderness will be present, and that is not consistent with a simple uncomplicated ulcer. So look for that abdominal distension because there's air in the abdominal cavity. Fever, and can go on to shock. This is obviously a surgical emergency. So look for a history of peptic ulcer disease with sudden worsening pain, bloating. The very first thing you're going to do in a patient with a history of peptic ulcer disease who now presents with suddenly worsening abdominal pain is to get an abdominal film. Very easy to get, relatively cheap, and it's diagnostic for a perforated ulcer. You look for subdiaphragmatic air, and I'll show you a picture of that. The treatment for this is immediate surgery. Gastric adenocarcinoma, malt lymphoma. Malt lymphoma can come on from an H. pylori infection. The treatment is interestingly the exact same if it's low grade. So these can kind of masquerade as one another. These are both malignancies. There's a 3% lifetime risk in patients with gastric ulcers. The symptom includes failure to respond to treatment. Obviously, if you have an adenocarcinoma, you're not going to respond to antibiotic therapy, for instance. It's going to be pretty refractory to proton pump inhibitors. Malt lymphoma, interestingly enough, if it's low enough grade, it can actually respond to triple therapy. So that's kind of a caveat with all this. Again, these are probably going to present with alarm signs, so you'll wind up doing an endoscopy, and then at that point you'll notice that there is a growth. You'll diagnose this with a biopsy and treat this with surgical resection, like I said, with the exception of those lower grade malt lymphomas. Gastric outlet obstruction is thankfully rare. Look for symptoms like early satiety, weight loss, and vomiting. Obviously, alarm signs. You're going to get a scope, and you'll notice it there. The treatment is surgical for that. So here's a perforated peptic ulcer. You can see a very dramatic presentation on abdominal film. Well, obviously this is a chest film, but you can still see the diaphragmatic air. So here it is. You see the diaphragm pushing way up into the chest cavity. So, chest x-ray, abdominal x-ray, you should see it either way. There's diaphragmatic air. Okay, gastritis. So this is the number 3 most commonly diagnosed cause of epigastric pain. This is a more generalized inflammation of the stomach tissue. So whereas with peptic ulcer disease, you have sort of like nicks or ulcers in the stomach or duodenum, this is just generalized inflammation. But otherwise, the integrity of the lining is fine. It's intact. Clinically, very difficult to differentiate from peptic ulcer disease, very similar symptoms. Like peptic ulcer disease, it usually presents with epigastric pain. It can be caused by all the same things. NSAIDs can cause gastritis, H. pylori can cause gastritis. The patient may have hematemesis or melena because of the inflammation. It can cause a little bit of bleeding, so it looks a lot like peptic ulcer disease. The difference from peptic ulcer disease is that gastritis can actually be caused by alcohol alone or by tobacco alone. So alcohol or tobacco is not going to be causative of an ulcer, but it can worsen an ulcer. Whereas with alcohol and tobacco, it can cause gastritis. This can be the causative point behind gastritis. Vitamin B12 deficiency may be associated with gastritis, and then a special condition known as atrophic gastritis, which we'll go into in a little bit. Your approach is going to be very similar. So you need to be wary of all the same alarm symptoms, and if those alarm symptoms are present, you should proceed to endoscopy because, we are thinking possibility of a malignancy with gastritis or with gastritis-like symptoms when it's present with alarm symptoms as well. So the first step in patients with no alarm symptoms, this is going to look very familiar to you, is to test for H. pylori and getting the serology. The patient should also have a CBC, a CMP, B12 and MMA, and an occult stool blood. So your approach is very similar. If you do have a positive H. pylori, then you'll start triple therapy and also reduce your risk factors like tobacco cessation, alcohol avoidance, etc. And that would hold true also for peptic ulcer disease. If it's a negative H. pylori, you're going to give a proton pump inhibitor. And then here's where we're concerned about your B12. If your B12 is low or you have a high MMA, which would suggest a B12 deficiency, then you're going to do B12 replacement, and you're also at that point going to test for antiparietal cell antibodies. At this point, we are trying to distinguish between a B12 deficiency and an actual cause behind that, which would be pernicious anemia, which we'll talk about very shortly. So gastritis due to B12 deficiency obviously is, by definition, gastritis caused by low B12 levels. Well, what would cause low B12 levels? Malnutrition or alcoholism. We know that alcoholism has a very, very strong association with B12 deficiency. Not all alcoholics are B12 deficient, but in the US, most people who are B12 deficient happen to be alcoholics. The symptoms, epigastric pain, and then issues related to their B12 deficiency. They can certainly become anemic. Look for a macrocytic anemia on your CBC. That would show fatigue and pallor. They may have reduced peripheral vibratory sensation on physical examination if that B12 deficiency is bad enough. Diagnosis, this is going to hinge on your labs. B12 levels will be low, MMA levels will be high. Almost universally, there'll be the macrocytic anemia. Remember, that's where your MCV is greater than 100, and then if you do a smear, you should see large red blood cells with your characteristic pattern. Negative antiparietal cell antibodies and anti-intrinsic factor antibodies, this is really differentiating this from pernicious anemia. The treatment here is going to be B12 replacement, and that can be given as a shot. Pernicious anemia is similar, but is different in cause. So pernicious anemia is an autoimmune gastritis, and it attacks the cells that are responsible for helping you absorb B12. So in effect, you get a B12 deficiency, but the cause here is not just regular old B12 deficiency that you're not getting enough in your diet. The cause here is that you're having an autoimmune attack against your stomach. Your stomach is not making intrinsic factor, and now you're not absorbing B12. So the history, look for a family history of pernicious anemia. For some reason, it tends to cluster in families, but I don't think the majority of them do have a family history. So that'll typically be absent, but a positive family history is suggestive. Symptoms include epigastric pain, fatigue, pallor, reduced peripheral vibratory sensation on physical examination, basically gastritis and B12 deficiency. Diagnosis, B12 low, MMA high, almost universally, macrocytic anemia. Again, looks just like the gastritis due to B12 deficiency. The difference here is that you're going to have a hypochlorhydria, which is a high gastrin. because those gastrin secreting cells are damaged. And then also positive antiparietal cell antibodies owing to the autoimmune nature of this, and anti-intrinsic factor antibodies. And that's what's causing those anti-intrinsic factor antibodies is what's causing the B12 deficiency. The treatment is going to be B12 replacement. You may have learned in medical school about the Schilling test. That's never the right answer on the USMLE, so you might as well just forget about that. So the way to diagnose pernicious anemia is by these antibodies. This is an autoimmune disorder, so we're going to diagnose this with antibodies. The Schilling test is no longer done. And then atrophic gastritis, wrapping up here, is the end stage of chronic gastritis. So any cause of gastritis, if you have it long enough, eventually you're going to result in atrophic gastritis. The only way you can diagnose this is with endoscopy and biopsy. With endoscopy, it can be clear macroscopically just by the decreased rugal folds. However, you'll also notice it on biopsy if you do that. This is due to chronic inflammation. That chronic inflammation can damage the parietal cells, and so everything that the parietal cells secrete will be reduced. So hydrochloric acid would cause an achlorhydria or a hypochlorhydria. And then because the parietal cells also secrete intrinsic factor, that can cause low B12 levels as well. So that can also show up as part of your symptoms for atrophic gastritis. There's really not a whole lot we can do for atrophic gastritis. Eliminate the causal agent, anything that's caused the chronic gastritis that's now ended with this atrophic gastritis. So you want to eliminate the causal agent. Often that's going to be H. pylori. So you'll want to test for H. pylori, and then if that's positive, you'll put them on triple therapy and eliminate that cause, and then correct complications. Typically, the major complication is the B12 deficiency. And do bear in mind that these patients with atrophic gastritis do have an increased risk of gastric carcinoma. So you'll want to follow up with them regularly, make sure and educate them as to what the symptoms are of gastric carcinoma. So they're keeping an eye on that. And that's all I have for you for peptic ulcer disease and gastritis. If you have any questions, please write me a note below. Otherwise, I will see you next time.